Hello, I'm Dr. Stephen Horwitz, and on behalf of CEC Oncology, I would like to welcome you to today's educational activity titled All Hands on Deck, a focus on current and emerging treatment options in the frontline setting for peripheral T-cell lymphoma. Today's program is supported by an independent educational grant from Pfizer Incorporated. Today's activity may include discussions of products or devices that are not currently labeled for use by the US FDA. Today's program is brought to you by CEC Oncology, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I'm Stephen Horwitz, and I'm a medical oncologist, member and attending physician at Memorial Sloan Kettering Cancer Center. Our learning objectives for today are to evaluate long-term efficacy and safety for first-line peripheral T-cell lymphoma treatments, to identify the diagnostic, prognostic, and therapeutic applications of CD30 expression in peripheral T-cell lymphoma subtypes, and lastly, to implement multidisciplinary strategies to enhance patient outcomes and therapeutic decision-making in PTCL. When we start thinking about T-cell lymphomas, I think we see that there are many diseases, but too often only one approach. This data shown here is historical data from the International T-cell Project, showing the range of the systemic T-cell lymphomas on the left and the outcomes on the right. In those days, and to a certain extent today, combination chemotherapy, primarily CHOP, was the main tool available. And what you can see is if you apply that same combination chemotherapy across the spectrum of diseases, you get a wide range of outcomes. This is the most current classification of peripheral or mature T and NK lymphomas. There's a WHO and an international consensus classification that came out in parallel. I'm just showing you the ICC here. But what you can see is that there are now more than 30 individually recognized clinical pathologic subtypes, some of them having their own specific management. We'll focus mostly on the systemic or nodal T-cell lymphomas. When we look at those primarily nodal T-cell lymphomas, and these are the various subtypes of anaplastic large cell lymphoma, angioimmunoblastic T-cell lymphoma, and the broader category of follicular helper T-cell lymphomas, which we'll talk about, and peripheral T-cell lymphoma not otherwise specified, you can see the outcomes here with fairly modern therapy. So this is a Swedish registry that really encompasses pretty much all the patients nationally with newly diagnosed T-cell lymphoma. Patients were almost exclusively treated with combination chemotherapy, CHOP, sometimes CHOP as topicide, sometimes the addition of transplant. And what you can see here is that the relatively more favorable ALK-positive anaplastic large cell lymphoma, which tends to be in younger patients with more favorable prognostic features, most of those patients will be cured with combination chemotherapy, 60 or 70%. And you can see the progression-free and overall survival curves in red. For most of the other types of systemic T-cell lymphoma, ALK-negative ALCL, angioimmunoblastic T-cell lymphoma, or PTCL-NOS, we see that the majority of patients will either not respond or progress soon after completion of their initial chemotherapy. And at least historically, overall survival curves have mirrored progression-free survival curves, reflecting the lack of effective agents at relapse. So when we think about PTCL, it's really a heterogeneous group of mature post-thymic T-cell lymphoma. Peripheral T-cell refers to a post-thymic T-cell, and the NK cell lymphomas and lymphoproliferative disorders get grouped with them. Altogether, they represent about 15% or so of the aggressive lymphomas and maybe up to 10% of all non-Hodgkin's lymphomas. Risk factors are mostly clinical right now, though we're starting to become a little more sophisticated with that, and include things like older age, advanced stage, multiple extranodal sites, poor performance status, etc. And as I showed in the previous slide, with the exception of ALK-positive anaplastic large cell lymphoma, most of the patients with peripheral T-cell lymphoma by subtype have a relatively poor progression-free and overall survival, at least when we compare to the more common aggressive B-cell lymphomas. Molecular characterization and deeper understanding of the biology has led to the identification of more subtypes, and we're starting to understand that these subtypes have different prognoses and starting to approach them differently therapeutically. And that data is emerging, but we'll show you some of that. So I think the first step is getting the diagnosis right. And with any rare cancer, particularly a rare lymphoma, getting the diagnosis right can be a challenge, but it's really important. differentiation by different kinds of lymphoma have to do with the morphology, but also site of involvement. And at least compared to B-cell lymphomas, a disproportionate number of T-cell lymphomas, the entities are classified partly based on their sites of presentation or sites of involvement. This is clear in something like anaplastic large cell lymphoma, which can be a nodal systemic disease, but there's also cutaneous and other forms that have a different prognosis and different treatment patterns. There's a number of enteropathy-associated T-cell lymphomas or T-cell lymphomas that present primarily in the GI tract, including enteropathy-associated T-cell lymphoma, monomorphic epitheliotropic T-cell lymphoma, and some of the NK lymphomas, which can present either in the GI tract, like what was called NK gastropathy, or the extranodal NK T-cell lymphoma, which is almost always in the nasal or oral pharynx. There's a number of T-cell lymphomas that present primarily or exclusively in the skin. And of course, something like hepatosplenic T-cell lymphoma is named because of the presentation primarily in the liver and spleen and bone marrow. We identified these initially based on lineage markers like T-cell or NK cell antigens, and then sometimes talk about the cell state or whether that is taking on the morphology of a follicular helper or germinal center T-cell, cytotoxic T-cell, or other type of mature T-cell. Most of the data we have are for the nodal T-cell lymphomas, and that's mostly what we'll focus on today. These are the most common in the US and Europe, and there's three main subtypes of these with some overlapping features. We talk about anaplastic large cell lymphoma, and I'll talk more about these in detail. Peripheral T-cell lymphoma, NOS, or not otherwise specified, meaning it doesn't fit into any of the other categories. And angioimmunoblastic T-cell lymphoma, and now that larger subtype of follicular helper T-cell lymphoma, which are again T-cell lymphomas derived from or have a cell state from a germinal center or T-cell. Expert pathology review is really critical in getting the diagnosis right, which gives you the best chance of making good clinical decisions. So PTCL-NOS, as one can imagine, in a not otherwise specified category, it's heterogeneous. There's variable cytological features. Most express an alpha beta T-cell receptor. We'll talk about that. Most are CD4 positive. When you look hard enough, CD30 is relatively commonly expressed. And one of the main overlaps with this would be ALK negative anaplastic large cell lymphoma, or one of the subtypes of follicular helper T-cell lymphoma. There are subtypes with CD8 positivity, primarily cytotoxic markers, and some of those cytotoxic PTCL-NOS subtypes probably have a different biology, and that understanding is an evolution. Probably the most common subtype now, it used to be NOS, but probably now it's the TFH types of T-cell lymphoma, angioimmunoblastic T-cell lymphoma, which has been described for a long time, and then some other types of T-cell lymphomas that share the same features of a follicular helper T-cell. These have follicular helper markers, and what we're learning is that most of these patients have their lymphoma develop on an abnormal genetic landscape, mostly clonal hematopoiesis, with very frequent mutations or alterations in TET2, DNMT3A, sometimes things like IDH2 or RhoA. And again, as I'll talk about near the end of the talk, these are starting to have some therapeutic implications, at least in terms of designing clinical trials. We identify follicular helper T-cell lymphomas by the presence of TFH markers. Most commonly, things looked for are CD10, PD1, CXCL13, and ICOS. Usually having two TFH markers is enough to call it a TFH lymphoma. And if you look down at the bottom right, most of these lymphomas will have a small population of B cells in the inflammatory microenvironment, and those B cells are often infected with Epstein-Barr virus. Anaplastic large cell lymphoma is named because if you look on the left, patients have these large anaplastic looking cells, often with a horseshoe or sometimes called donut-shaped nucleoli. These cells are universally strong expressors of CD30, ALK positive, or ALK will be expressed in the ALK positive anaplastic large cell lymphoma, absent in the ALK negative variety, and things like EMA are frequently expressed. Anaplastic large cell lymphoma is interesting for a number of reasons, but one of them is that there's different clinical behaviors and different prognoses and treatment based on the site of involvement. So for the systemic subtypes, which we treat with combination chemotherapy, we have ALK positive that has relatively favorable prognosis. and systemic ALK negative that has a more poor prognosis, though there are some genetic factors like DUS22, which may shade the overall prognosis. Again, those patients are all treated with combination chemotherapy. When those same appearing ALK negative anaplastic large cells present exclusively in the skin, we call that primary cutaneous ALCL, and that really has the biology or the clinical prognosis of an indolent lymphoma, with presentation usually in the skin and chronic relapses usually confined to the skin, with rare dissemination outside the skin and excellent prognosis. And then there's a more newly understood breast implant associated anaplastic large cell lymphoma, which is an ALK negative anaplastic large cell lymphoma that develops exclusively in the fluid or seroma between a textured breast implant and the fibrous capsule. And that's an interesting disease that is usually treated just surgically. So we'll start with the patient case. A 65-year-old man with no significant comorbidities presents with fevers, night sweats, some unexplained weight loss, and his physician notes some left axillary lymphadenopathy. A biopsy of that lymph node shows large cells with horseshoe-shaped nuclei, staining positive for CD2, CD4, CD5, CD30, EMA, negative for T-cell marker like CD3, no CD8, CD15, probably excluding Hodgkin lymphoma, and negative for ALK1. PET-CT shows splenomegaly, axillary and retroperitoneal adenopathy. So what type of lymphoma does this man have, and what are his best treatments? So when we think about diagnosing a T-cell lymphoma, we look at the clinical features. This person presents with nodal disease. We want a biopsy, usually want a fair amount of tissue. So this is often an excision or could be multiple cores. It's very hard, if not impossible, to make a clean diagnosis, a new diagnosis of T-cell lymphoma on an FNA alone, because some of the morphology and the other features are important. Immunohistochemistry really defines the lineage as T-cell and then helps us subclassify between the different types of T-cell lymphoma. And then we often can use genetics to look for things like T-cell clonality or other genetic or cytogenetic characteristics that may help us define a specific entity. More and more, we're doing comprehensive genetic profiling or next generation sequencing to look at mutations, and that's helping us understand more about the biology of T-cell lymphomas and sometimes suggesting treatment options. I think this slide is important and it's confusing to a lot of physicians. We talk about T-cell receptor expression versus rearrangement. So a normal mature T cell will have a T cell receptor on its surface, and that T cell receptor on the surface will either be an alpha beta, which is most T cells and most T cell lymphomas, or a gamma delta, which are more common in T cells of the innate immune system, often in the GI tract, mucosal surfaces, and sometimes other places. And those lymphomas of gamma delta T cells will have a gamma delta expression on its surface. When T cells develop, the gamma and delta genes are rearranged clonally before the alpha and beta genes. And then when you have rearrangement in an alpha gene, you get deletion of the delta gene. So this is where it gets a little confusing. So alpha beta expressing T cell lymphomas, which are most of our T cell lymphomas, often will still have a gamma chain rearrangement. And when we look at tests of clonality to see whether all the T cells are genetically identical to one another, the gamma chain is one of the most frequently looked for. So in that sense, alpha beta T cell lymphomas might also have a gamma chain rearrangement. So when we define clonality, we look for rearrangements of the T cell receptor genes like gamma. We can look at that by fragment analysis or next-gen sequencing. But when we talk about the subtype of T cell lymphoma, we're referring to the expression of an alpha beta or gamma delta T cell receptor on the surface, and that sometimes helps define the subtype. Hopefully that was not totally confusing. So back to our population, this would be our jumping off point for treatment. If we think this is historically what we do with modern therapy and good supportive care, you can see again that most patients with ALK positive ALCL are cured. The majority of patients with the other nodal subtypes of T-cell lymphoma are not cured. So if that's the data with CHOP, what can we do to try to improve those results? Historically, the most successful or most used option has been dose intensification. So if chemotherapy cures some, can more chemotherapy cure more? And we have some data for that to suggest that more intensive chemotherapy is helpful, although the data is not unequivocally certain. So one of the more common modifications to combination chemotherapy, CHOP, is adding etoposide or CHOEP. The benefit for this in T-cell lymphomas comes from the German studies that were done prior to rituximab being used consistently for B-cell lymphomas. where patients were treated with CHOP or CHOP plus etoposide on every 2-week or every 3-week schedules. And there was a study with older patients over 60 and a study with younger patients under 60. If you look at the patients under 60 and analyze just the T-cell lymphoma patients, who are about 10% of the whole study, you can see that on the top left, there was a benefit in terms of event-free survival for young patients by adding etoposide every 2 weeks or every 3 weeks. If you look on the top right, numerically, most of that benefit were in the already more favorable ALK-positive ALCL patients. Those patients tend to be younger as well. And if you look on the bottom left, for the other subtypes of T-cell lymphoma, there was a trend towards benefit in event-free survival, but no difference in overall survival. And again, this was a subset analysis of this study, looking just at T-cell lymphoma patients. One of the things that comes out is that when you add etoposide, you do get more toxicity, and that's primary hematologic toxicity. So on the top right, if you look at the patients in the B1 study, which were the younger patients, they did have more effects on blood counts, but those effects didn't translate into significant increases in infection or mucositis, or things that either compromise safety or compromise dose intensity. However, if you look on the bottom right, in the older patients, age 61 to 75, you see that those increases in cytopenias did translate into clinical consequences with significantly more infection and mucositis. And in the older patients, any potential benefit in terms of efficacy with etoposide is kind of wiped out or overridden by these additional clinical toxicities. The other type of dose of intensification that has been looked at and is frequently done, and this is how we tend to practice, is adding high-dose therapy on autologous transplant for patients in first remission after initial therapy with T-cell lymphoma. We have no randomized data to support that. The best data set to suggest that is a prospective phase 2 study done in the Nordic countries, where 160 patients were treated with CHOP plus etoposide every 2 weeks, so dose dense and dose intense, CHOP in patients over 60. And those patients who responded partly or completely went on to receive high-dose therapy and autologous transplant. And if you look at that data by intent to treat, you see the 5-year overall survival just over 50%, 5-year progression-free survival at 44%. And many of us think that this may be better than what we saw with those historical controls, or that if you add more intensive chemotherapy to responding patients, you may do better in terms of overall progression-free and overall survival. Again, though not a randomized study, and certainly selection bias can filter into a prospective study. When you look at the different subtypes of T-cell lymphoma, we get into this issue of heterogeneity again, and you see that the benefits may not be uniformly distributed. So if we just look at the 5-year overall survival, you see the best results are those with ALK-negative ALCL. Here, 70% of those patients by intent to treat were alive at 5 years, many of those patients in remission. Less good results for AITL and then NOS and enteropathy-associated T-cell lymphoma. So dose intensity may help, and it may most help those with chemosensitive disease, such as ALK-negative ALCL. We and others are interested in trying to understand who will benefit from chemotherapy and dose-intense chemotherapy. If you're going to be cured with chemotherapy, even though there's toxicity, it's better to be cured with T-cell lymphoma. But right now, we don't have good tools other than treating patients and see how they respond. Some early looks have identified some adverse clinical prognostic features that we think may be associated with lower chance of benefit for chemotherapy. Some of that can be mutations that go along with chemo resistance, such as TP53 or CDKN2A. There's some data showing chemo resistance for certain subtypes, certain mutations with DNMT3A, and TP63 looks in anaplastic large cell lymphoma, and PTCNOS looks to highly correlate with resistance to chemotherapy. DUS22 in anaplastic large cell lymphoma may be a more favorable characteristic, like ALK1 expression. When we looked at our next generation sequencing, this done by one of my colleagues, Bill Johnson, we saw that if we looked at patients overall with TP53 mutations or CDKN2A mutations, which are a minority of the patients, that those patients were much less likely to benefit from an intensive combination chemotherapy approach than those with unaltered TP53 or CDKN2A. So how can we do better? So one of the ways to do better has been to try to add new therapies on top of combination chemotherapy to T-cell lymphoma, and the most successful attempt at that so far has been with brentuximab vedotin. So if you look back at the phase 2 studies of brentuximab vedotin, this is a CD30-directed antibody drug conjugate. In the phase 2 study of initial approval for anaplastic large cell lymphoma on the left, the overall response rate was 86%, with more than half of those patients having complete responses and pretty good durability. When we've looked at other subtypes of T-cell lymphoma, such as angioimmunoblastic T-cell lymphoma or PTCL-NOS, we see good response rates, lower complete response, and shorter durations of response. Nonetheless, this was a logical medication to combine with combination chemotherapy. CD30 expression is common in peripheral T-cell lymphoma, and part of it depends on how hard you look. So I'll just show you two series that were done at different points in time, actually by the same pathology group. Initially in 2006, they used a cutoff of CD30 expression on 30% or more of the tumor cell population, and they saw relatively low rates of CD30. As we started to have more CD30 directed therapy, the same group did a larger look, now lowering it to 25% of cells and allowing less intense CD30 expression to call it positive. And you can see on the right that if you take that lower bar threshold, many of the patients with T-cell lymphoma have at least a proportion of their cells expressing CD30. So even now, interpretation of CD30 expression is not universally standardized, and it kind of depends on what question you're asking. But taking that idea that we had an effective agent, brentuximab vedotin, in CD30 positive T-cell lymphomas, and that CD30 was commonly expressed on T-cell lymphomas, that led to the Echelon-2 study after a phase 1 showing some promise with combining brentuximab vedotin with combination chemotherapy. So in this study, patients were randomized to brentuximab vedotin plus CHP, so that's CHOP chemotherapy, holding the vincristine for concerns about overlapping neurotoxicity, or CHOP alone. And this was a double-blinded study where patients got BV-CHP plus placebo vincristine or CHOP plus placebo brentuximab. If you look at the eligibility criteria on the left, so these were adult patients that had to have CD30 expression defined as greater than or equal to 10% on their tumor cells. So this would be everybody with anaplastic large cell lymphoma. Patients with the more favorable ALK-positive ALCL had to have at least an IPI risk factor of 2 to identify a higher risk population. And then patients with other types of T-cell lymphoma had to meet that CD30 criteria. 10% was not picked because we know there's a lower threshold of activity, but because this was an upfront study of aggressive disease, we wanted patients to be enrolled based on the local pathology. And it was felt that a positivity of 10% would stand up to central review, and a lot of patients wouldn't be thrown out as being truly CD30 negative. And the other important thing to note about this study on the bottom left is that the study was designed to look at the overall intent to treat population as well as the anaplastic large cell lymphoma population independently. So that was targeted to have about 75% of the patients be ALCL. That means that the other types of T-cell lymphoma were not balanced or powered to be looked at as independent subsets, and we'll talk about that. So these are the patients who were treated. Median age was 58, which is a little lower than your average patient with T-cell lymphoma. As usual with T-cell lymphoma, most patients had advanced stage disease, 80% stage 3 or 4 disease. And as planned, about 70% of patients had systemic anaplastic large cell lymphoma. About half of all patients in the study had ALK-negative ALCL. And you can see the relatively lower numbers of other subtypes of T-cell lymphoma represented. And these were the results. So these are the updated 5-year results, but they held up from the initial results. And that was a benefit in progression-free survival for BV-CHP, almost 3 times the PFS for CHOP, and a benefit in overall survival with BV-CHP with a hazard ratio of 0.72. So benefit in progression-free and overall survival by intent to treat. I'd like to point out here, too, that the CHOP arm actually did quite well. So sometimes you'll hear, well, combination chemotherapy doesn't work well in T-cell lymphoma. Well, in this study, at least almost 50%, just under 50% of patients on the CHOP arm were progression-free at 4 years, and the median overall survival for the CHOP arm was not met at 5 years. So a substantial subset of patients were cured with CHOP alone. When you look at the other subtypes of T-cell lymphoma outside of ALCL, the interpretation gets a little less clear. So if you look at PTCL-NOS on the top left, that's progression-free survival was almost tripled, but the curves come together at about 3 years. And there's no significant statistical difference in overall survival, although the medians are numerically quite different. When you look at angioimmunoblastic T-cell lymphoma, the results are harder to explain. So here in the CHOP arm, The median progression-free survival was 4 years, which was better, numerically better, not statistically different than BVCHP. And the overall survival was actually quite good for AITL for both arms, but really no difference. These smaller subsets have wide confidence intervals, and there's no statistical difference between the two groups here. When we try to drill down on CD30 expression in echelon 2, now the anaplastic large cell lymphomas were all universally CD30 expressing. If we look at the other subtypes of T-cell lymphoma with PTCL-NOS, you can look at response by CD30 expression. And what you can see is that there's not an obvious correlation. Many of the patients had low levels of CD30 expression, 10 to 20%, and no obvious difference there in terms of whether they were a responder or not. In patients with angioimmunoblastic T-cell lymphoma, if anything, we see relatively lower rates of CD30 expression, and again, no real difference as to response or outcome based on your level of CD30 expression. Remember, everyone in the study had to have a local review of at least 10% CD30 expression. When we look at toxicities, I think the other reason that this study was successful is that there was no significant increase in toxicities when brentuximab was added to CHP. If you look at this plot of the main toxicities, the blue or teal curve bars are BVCHP, the purple bars are CHOP, the darker shades are grade 3 to 4, the lighter shades are grade 1 to 2. And if you look across the board, there's really no clear difference in toxicity between the two arms, with the exception of diarrhea, which was more common with BVCHP than CHOP. Even if you look at peripheral neuropathy, the relative rates of peripheral neuropathy were similar. What about brentuximab plus dose intensification? So because many of us practice with consolidating remissions with auto transplant, this was allowed in the echelon 2 study, but it was by investigator's choice, not pre-specified and not randomized. And when you look at that, again, this is subset analysis. If you look on the left, these are patients with ALK-negative anaplastic large cell lymphoma who had a transplant or not in first remission. And again, the transplant curve sits above, hazard ratio of 0.35, but not a prospectively designed endpoint. And if you look on the right, patients with PTCL, NOS, or AITL, again, the transplant curve sits above the non-transplant curve, has a ratio of 0.46, but wide confidence intervals. But I think this suggests that if your bias is towards consolidating with transplant, that's still a reasonable thing to do even after BVCHP. So conclusions from that study about adding brentuximab to a CHOP or CHP backbone in untreated peripheral T-cell lymphoma. So in ALCL, there's an overall survival benefit. This is really now the standard of care and pretty much the standard of care around the world. In patients with other CD30 expressing peripheral T-cell lymphoma, angioimmunoblastic T-cell lymphoma, well, it's a little bit in the eye of the beholder. These patients were part of the intent to treat population, and there's an overall survival benefit. So there's a risk of being wrong if you hold it out. However, as I tried to show you, the smaller subset size precludes statistical conclusion. And when you look at the curves, adding BV is of unclear benefit. But importantly, there's no additional toxicity. So I kind of look at it as, are you adding BV versus what's the alternative? And we'll talk a little bit about that. I didn't show you data for this, but there are some studies looking at more intensified regimens, adding etoposide to BVCHP and following that with auto transplant. And then an enteropathy-associated T-cell lymphoma, which is almost always CD30 positive. There's a study from France looking at a similar approach, BVCHP, plus some additional chemotherapy, plus auto transplant, that looks quite promising for that disease. So we come back to our patient. In consultation with the patient, by the way, he had ALK-negative anaplastic large cell lymphoma. It was decided he would receive BVCHP at standard dose. So what pre-medications or education would you provide the patient? So infusion reactions are rare with brentuximab, but we do sometimes give some standard pre-medications for reactions and steroids, which can also prevent nausea. The chemotherapy portion of this does carry a fairly high emetogenic risk. So we do use our standard antiemetic prophylaxis pre-treatment and then to take home after treatment. We do use G-CSF prophylaxis for this treatment. On the study, it wasn't mandated that you get G-CSF prophylaxis on the echelon 2 study, but there's lower rates of neutropenia and neutropenic fever when GCSF prophylaxis was given. So we always give GCSF prophylaxis with this regimen. There have also been some reported cases of PJP, though this wasn't seen in the Echelon 2 study. So our practice is also to give PJP prophylaxis as well as VZV prophylaxis. There is a black box warning with brentuximab, PML, which is very rare. There have been a handful of cases, but this is a black box warning. It's something that patients are counseled about when we start this therapy. I think the most common side effect we think about with brentuximab is peripheral neuropathy, and this often starts as a sensory neuropathy, and if not, and it should be followed. If it progresses, it can become more severe sensory neuropathy or progress to motor neuropathy. So in the study, there was guidance that if patients develop grade 2 neuropathy, there would be a dose reduction in brentuximab, and then for grade 3 or higher, we would hold brentuximab. Most patients with those dose modifications can get through 6 cycles of chemotherapy with brentuximab. The NCCN has some guidance for neuropathic pain, and they're just referenced here. If patients develop neuropathy that's uncomfortable, there are some medication guidances in how to best manage that. So our patient received brentuximab CHP, he has grade 2 neuropathy and fatigue, but completes 6 cycles, has a remission, and remains on observation with expected monitoring without evidence of disease over 3 years from the end of treatment. So that's a patient without negative ALCL. How might you think about this patient differently if they had angioimmunoblastic T-cell lymphoma or another type of T-cell lymphoma? So again, I'll remind you of the curves that the data for BV-CHP is most clearly beneficial for those with anaplastic large cell lymphoma, less clear for patients with PTCL-NOS or AITL, although we do use it for those patients at times. Well, we have nothing proven yet, but we're starting to get some clues that there may be some other types of treatment that may be more effective, for instance, in follicular helper T-cell lymphoma. So this is data just looking at histone deacetylase inhibitors, primarily romidepsin or belinostat, and looking at patients who are treated off study or on study with a follicular helper or a non-follicular helper subtype of T-cell lymphoma. And what you can see is that responses and complete responses are much more frequent for patients with follicular helper T-cell lymphoma than non-TFH lymphomas when treated with an HDAC inhibitor. And this strategy was looked at in an upfront study, the RO-CHOP study. So this was a study done in France adding romidepsin, which is a histone deacetylase inhibitor, to CHOP or CHOP alone. And it was a prospective randomized study similar to Echelon 2. This was mostly patients with the more common nodal subtypes of T-cell lymphoma. Patients did not get consolidation with transplant, and the primary endpoint was progression-free survival. That study ended up being a negative study, and when you look on the left at responses, there was really no difference in response or complete response to romidepsin plus CHOP or CHOP alone. But when you look on the right, unlike adding brentuximab, adding romidepsin did result in significant increase in toxicity. That was primarily hematologic toxicity that led to more frequent dose reductions and dose interruptions and reduced the overall dose intensity of the chemotherapy part, which, as I showed you before, we think is important for curing patients. When you look at the progression-free survival and overall survival curve, there was really no difference between RO-CHOP and CHOP for either PFS or OS. However, a subset analysis was done looking back at the follicular helper patients who were almost half the patients in this study. And when you look on the left at the patients with follicular helper T-cell lymphoma, you see an almost doubling of progression-free survival. And on the right, you see really no difference for the non-TFH patients. And if anything, the RO-CHOP curve sits below CHOP curve. There's other therapies that also look promising in T-cell lymphomas, including hypomethylating agents, PI3 kinase inhibitors, EZH inhibitors, and JAK-STAT inhibitors. I'll talk a little bit about a few of these. So azacitidine was initially looked at in a small series in patients with T-cell lymphoma, and initially it was observed that responses were pretty much only in the patients with the angioimmunoblastic T-cell lymphoma. Some of those responses were complete and durable, again, not a clinical trial, but a case series. This was then formally studied in a prospective randomized study of oral azacitidine versus investigator's choice, which included things like gemcitabine or bendamustine and romidepsin. And in that study, the overall response rate was a little more realistic, 33% for oral azacitidine, though some of those responses were durable. Azacitidine was looked at in an upfront study. This is a phase 2 led by Jia Ruan at Cornell, adding CC486 or oral azacitidine to CHOP. This was a pilot study that we participated in, and initially the data looked quite good. So the overall response rate for all patients on study was 75% and 88% in the patients with the follicular helper T-cell lymphoma subtype. In a relatively short follow-up, you can see the curves on the bottom left, and they look quite good. The azacitidine did result in some increased toxicity, primarily hematologic toxicity, but most patients in this small pilot study could complete the therapy as planned. There was a bit of a look at genetics, and if you look at the top right, TET2 alterations, which mostly goes along with follicular helper T-cell lymphoma, patients did correlate with a favorable progression-free survival. And as we've seen in some other studies, some of the patients with TFH lymphomas with DNMT3A mutations do seem to do worse in terms of progression-free or overall survival. Small study here, but it looked like that same prognostic impact of genetics may hold. Other targets in T-cell lymphoma that have been looked at include things like PI3 kinase, AKT-mTOR pathway. So this is data from the phase 2 study, the last updated data of the PRIMO study, which is a phase 2 study of duvelisib for relapsed or refractory peripheral T-cell lymphoma. And you can see that the overall response rate here is almost 50%. And if you look by subtype, those responses are not evenly distributed. So patients with angioimmunoblastic T-cell lymphoma had a 67% response rate, over 50% complete response rate, and looks to be much more effective in that subtype than, for instance, anaplastic large cell lymphoma, which had less than a 15% response rate. And this study is being developed both in the relapsed setting and being looked at up front. So based on some of that preliminary data that I showed you, the U.S. cooperative groups have an intergroup study led by the Alliance, which is looking at upfront chemotherapy with either duvelisib or oral azacitidine or a control of CHOP or CHOP alone. Patients under 60 get CHOP plus etoposide plus a novel agent or not. Patients over 60 get CHOP plus a novel agent or not. And that's an ongoing study that's available in the U.S. So to wrap up here, peripheral T-cell lymphoma, I think I showed you that it remains heterogeneous. Outcome and treatment is based on subtype and overall more poor prognosis than we'd like. However, I think we're doing better, certainly in some areas. I tried to show you that there are some patients cured with combination chemotherapy alone, and maybe adding more intensive chemotherapy, etoposide or auto transplant, pushes up that cure rate a bit. We're learning that prognostic factors can impact prognosis and also decision-making and individualizing therapy. So pre-treatment, things like subtype are routinely used, like anaplastic large cell lymphoma or not, to help pick treatments. And we're starting to learn about mutational profiling, though I'd say that's a little bit of a risk stratification that truly identifies individual treatment right now, and that's a work in progress. There's some data on interim treatment response, what I just showed you today, but that can also predict who's doing well with the current therapy or who needs a change. There's previous and ongoing attempts to incorporate new therapies into combination or upfront regimens to try to increase the cure rate. This is really focused on identifying active agents like was done with brentuximab, enriching the population for those most likely to respond, in that case CD30 expression, and then hopefully minimizing toxicity so it doesn't impact the overall dose intensity of chemotherapy, which we still think is important in curative intent treatment. Our best example of that is brentuximab vedotin plus CHP, which has an overall survival benefit for patients with CD30 expressing peripheral T-cell lymphoma. And again, I showed you that that data is most sound for those with anaplastic large cell lymphoma, and showed you the data for angioimmunoblastic T-cell or peripheral T-cell lymphoma NOS, where that's still a standard regimen on label that used up front, but because of the small subset, that data is a little less clear. And we talked about some other approaches that are being looked at, particularly in the follicular helper T-cell lymphoma subtypes. So I'll just leave you there with maybe food for thought. If we look on the left, these are some of our current treatment paradigms for standard treatment for patients with a newly diagnosed T-cell lymphoma. For CD30 positive patients, BVCHP is standard. And for CD30 negative patients, we often think about CHOP, or many of us think about dose intensity like CHOP plus etoposide. And we frequently consider auto transplant for those in first remission as a way of consolidating or potentially increasing the duration of remission. But one could imagine in the future on the right, and some of this I didn't talk about, that we may have more biologically individualized therapy. If CHOP or combination chemotherapy is still an important part of curative intent, we can add other agents, maybe based on the biology or the data in the relapse setting to different subtypes of T-cell lymphoma. And those could be things like PI3 kinase inhibitors, JAK-STAT inhibitors, or I showed you the emerging data for epigenetic modifiers for those with follicular helper T-cell lymphoma. And then there are a group of patients with fundamentally chemo-refractory disease down on the bottom right that may need a wholly different approach. And it may be for those patients that incrementally building upon chemotherapy is not a successful strategy, and we need to find or identify wholly different approaches. So I think when we care for patients with T-cell lymphoma, it's really a team-based approach, and we have a big team that's really supportive. I think the hematologist or oncologist is often making the decisions and outlining the plans. As I tried to show you, the pharmacists, oncology nurses, and our oncology advanced practice providers are really important in helping care for the patients, managing their treatment, managing their toxicity. And there are some selective uses of radiation oncology here that we didn't go into that. And then, of course, at the center of all this, and the reason we do this, is the patient and their caregivers. Lastly, let me leave you with some SMART goals, which are smart, measurable, attainable, relevant, and timely. I think for this activity, incorporating the latest clinical trial data regarding CD30-directed therapy in the care of your patients with peripheral T-cell lymphoma. Provide ideal patient care by involving the whole care team and document patient education and guidance concurrent therapy administration, including things like prophylaxis and supportive care. Again, thank you for joining me today, and thank you for providing the very best